So we take a quick look at the management of DKA. Some of our management goals will be correction of fluid loss with intravenous fluids, correction of hyperglycemia with insulin, correction of electrolyte disturbances, particularly potassium loss, correction of acid-base balance, and treatment of concurrent infection if present. Alright, so let's look at some investigations. Before that, diabetic ketoacidosis is typically characterized by hyperglycemia over 250 mg per deciliter, bicarbonate level less than 18 milliequivalent per liters. We have pH less than 7.3 with ketonuria and ketonuria. Some laboratory studies for DKA should be scheduled as follows. Plasma glucose study greater than 250 mg per deciliter. Blood test for glucose every 1 to 2 hours until patient is stable, then every 4 to 6 hours. Urine dipstick testing that is positive for glucose and ketones. Serum electrolyte panel. The serum electrolyte determinations every 1 to 2 hours until patient is stable, then every 4 to 6 hours. Serum potassium levels initially are high or within the reference range in patients with DKA. Initial blood urea nitrogen frequently is increased in patients with diabetic ketoacidosis. Arterial blood gas frequently show typical manifestation of metabolic acidosis, low bicarbonate and low pH that is less than 7.3. The complete blood count, even in the absence of infections, shows an increased white blood cell count in patients with DKA. The high WBC counts or marked left shift may suggest underlying infections. Cultures, urine and blood culture help to identify any possible infecting organisms in patients with DKA. We're looking also at imaging studies in DKA. We can carry out ECG, that is electrocardiogram, or consider telemetry in patients with comorbidities, especially cardiac conditions, known significant electrolyte abnormalities, severe dehydration, or profound acidosis. You can also do the chest radiography to rule out pulmonary infections such as pneumonia. Then do head-computed tomography, that is CT scanning, to detect early cerebral edema. Use low threshold in children with DKA and altered mental status. The head magnetic resonance imaging, that is MRI, to detect early cerebral edema. Now, order this only if altered consciousness is present in elderly patients. Now we're looking at the correction of fluid loss. Initial correction of fluid loss is either by isotonic sodium chloride solution or by lactated Ringer solution. The recommended schedule for restoring fluid is as follows. Administer 1 to 3 liters during the first hour, then 1 liter during the second hour. You then administer 1 liter during the following 2 hours, then administer 1 liter every 4 hours, depending on the degree of dehydration and central venous pressure readings. Note that within 12 hours, you have administered at least 6 liters of fluids. When the patient becomes euvolemic, the physician may switch to half the isotonic sodium chloride solution, particularly if hypernatremia exists. Isotonic saline should be administered at a rate appropriate to maintain adequate blood pressure and pulse, urinary output, and mental status. If a patient is severely dehydrated and significant fluid resuscitation is needed, switching to a balanced electrolyte solution, example, normal Sol R, in which some of the chloride in isotonic saline is replaced with acetate, may help to avoid the development of hyperchloremic acidosis. When blood sugar decreases to less than 180 mg per deciliter, isotonic sodium chloride solution is replaced with 5 to 10% dextrose with half isotonic sodium chloride solution. After initial stabilization with isotonic saline, switch to half normal saline at 200 to 1000 ml per hour. Insulin should be started about an hour after IV fluid replacement is started to allow for checking potassium levels and because insulin may be more dangerous or less effective before some fluid replacement has been obtained. Now let us go through the insulin therapy in DKA. When insulin treatment is started in patients with DKA, several points must be considered, and these are as follows. 1. A low-dose insulin regimen has the advantage of not inducing the severe hypoglycemia or hypokalemia that may be observed with high-dose insulin regimen. 2. Only short-acting insulin is used for correction of hyperglycemia. And 3. Subcutaneous absorption of insulin is reduced in DKA because of dehydration. Therefore, using intravenous routes is preferable. The initial insulin dose is a continuous IV insulin infusion using an infusion pump, if available, at a rate of 0.1 units per kilogram per hour. A mix of 24 units of regular insulin in 60 ml of isotonic sodium chloride solution usually is infused at a rate of 15 ml per hour, that is 6 units per hour, until the blood glucose level drops to less than 180 mg per deciliter. The rate of infusion then decreases to 5 to 7.5 ml per hour, that is 2 to 3 units per hour, until the ketoacidotic state abates. Then you shift to sliding scale if the BGL reads 12 to 13 millimoles per liters. We are going to walk through the electrolyte correction in DKA. Take note of the following. If the potassium level is greater than 6 milliequivalents per liters, do not administer potassium supplements. If the potassium level is 4.5 to 6 milliequivalent per liters, administer 10 milliequivalents per hour of potassium chloride. If the potassium level is 3 to 4.5 milliequivalent per liters, then administer 20 milliequivalent per hour of potassium chloride. Monitor serum potassium levels hourly, and the infusion must be stopped if the potassium level is greater than 5 milliequivalent per liters. The monitoring of serum potassium must continue even after potassium infusion is stopped in the case of expected recurrence of hypokalemia. In severe hypokalemia, not starting insulin therapy is advisable unless potassium replacement is underway. This is to avert potentially serious cardiac dysrhythmia that may result from hypokalemia. Potassium replacement should be started with initial fluid replacement if potassium levels are normal or low. Add 20 to 40 milliequivalents per liter of potassium chloride to each liter of fluid once the potassium level is less than 5.5 milliequivalent per liters. Potassium can be given as follows. That is 2/3 of potassium chloride or 1/3 as potassium phosphate. Let us look next at the correction of acid-base balance. Sodium bicarbonate only is infused if decompensated acidosis starts to threaten the patient's life, especially when associated with either sepsis or lactic acidosis. If sodium bicarbonate is indicated, 100 to 150 mL of 1.4% concentration is infused initially. This may be repeated every half hour if necessary. Rapid and early correction of acidosis with sodium bicarbonate may worsen hypokalemia and cause paradoxical cellular acidosis. Bicarbonate typically is not replaced as acidosis will improve with the above treatment alone. Administration of bicarbonate has been correlated with cerebral edema in children. In the treatment of concurrent infection, the administration of proper antibiotics is guided by the results of culture and sensitivity studies. Starting empiric antibiotics on suspicion of infection until culture results are available may be advised. Now let us look at some differential diagnoses of DKA. There's acute pancreatitis, alcoholic ketoacidosis, appendicitis, urinary tract infection, and cystitis in females. There's also hyperosmolar coma, hypophosphatemia. We have also hyperthermia, lactic acidosis, and metabolic acidosis. We are going to look at some complications associated with DKA, and these include sepsis and diffuse ischemic processes. Other associated complications may include myocardial infarction, deep vein thrombosis, acute gastric dilatation, erosive gastritis, late hypoglycemia, respiratory distress, infections, normally UTI, hypophosphatemia, mucormycosis. Then we also have cerebrovascular accidents and then septic shock. This brings us to the end of the condition DKA. I hope you enjoyed the lesson today. Stay tuned for our next lecture.